Welcome, everyone. So, I'm Dr. Victoria Reinhardt with MIH Academy and Mobile Health Consultants. MHC is a consulting and education company, and I'm going to introduce my partner in crime here, Dr. Molly O'Neill. Many of you know her already from the Academy. I'm going to turn it over to her and let her say hello.
It's exciting to be here, and we want to thank IBSC for this partnership opportunity. And what we're going to try to do is talk through some of the take-home points of this progressive case study that we've been working on this week. So we're going to start with part one.
We're excited. So, looking at part one of this case, this is essentially a patient that gets referred to your program. You can see some details about the program. This is an example of a program in a suburban area that, sees about 8 to 10 patients per shift. And we really want to make sure that as you're starting to digest this case, the thoughts that are going through our minds include, thinking about community health in general. What does this start to tell you about the community health in your area, or what type of program focuses you should include? And as always, anytime you're looking at a high level overview of a program, starting to think about priorities from a stakeholder standpoint of, what your community is, what your city is, what the local hospital is. All of those are good things to keep in mind. We do want to jump right into our patient here. And, we have our patient, an 83-year-old female that was referred to your program post hospitalization for COPD and with recently diagnosed diabetes. We had some engagement pieces here where we wanted you to scan the QR code and take a look at her discharge history. I'm going to pop that up on the screen, Molly.
Hmm?
So when you scan this, we can see here that we have some discharge orders from our patient. And Molly, what sticks out at you here when we start to look at this?
If we have looked at one MIH program, we say that we've only seen one MIH program. So from the previous slide, we're keeping in mind that this is a program that is doing looking at hospital discharges as a high priority. And this particular patient is discharged with a couple of things: new onset diabetes, and then also a COPD exacerbation. And when we look at these, first at the medications, there's a few things that sort of stick out with us, and we'll get to that in the questions. But what pops out to me automatically is that she's got some different types of inhalers and perhaps nebulizer medications to be using, that she has been started out on metformin and on insulin. So there's two different diabetic medications that she's on. And then there's a couple of other medications that are thrown in here, more from a cardiac standpoint. There's the metoprolol and pravastatin, and then also the apixaban and digoxin, which the case doesn't lead us to the reason that she's on that. It's really focused more on the COPD and the diabetes, but we always bear in mind that no one has just one chronic disease. There's always a myriad of other diseases that go along with it. And she's sent to all of these appointments: endocrine, nutrition, pulmonology, primary care. And there's a lot of social determinants that come into play with these diagnoses, especially with the nutrition part, the transportation part, even the financial part. So I noticed too that she has primary care referral, but then there's no number. Like, who is the primary care? Does she have primary care? And while specialty appointments are great, where is this patient's medical home? Who is going to coordinate this for her? So that's a big red flag for me, that she does not have a medical home with primary care.
Yeah, I would echo that. And also, from a clinical standpoint, of course, my background being in medication management, the medications automatically start to trigger for me what are the risks here that we may need to be managing, and what are the components that we need to put in place from a care plan standpoint to help reduce the risk of a medication related issue or her, ending up back in the hospital within the next 30 days for a hospital readmission. And so, we're starting to look at some of these medications. She's on a couple different high risk medications. So you can see something like digoxin there. So digoxin toxicity in elderly females is a big issue that we're concerned about. We've got some blood pressure management issues here. So we're wanting to make sure that we are educating the patient, that we're going in doing that vitals check, seeing how at risk she is for hypotension, if she's still hypertensive and might have an issue with that. We know also that Eliquis, right? It comes with its own risks of bleeding. So already just starting to look at, the patient presentation, right? Why she was referred. We've got some high risk conditions there for hospital readmission. We've got some high risk medications here. All of those can contribute. So that's a great segue, I think, Molly, into what our discussion questions are for part one here. And our first discussion question, we'll kind of high level overview it if you're driving, but essentially looking at the discharge records, what is the patient's problem list? And you always want to be kind of thinking, highest priority. What's the highest risk, or what's going to kill them first, or what's the most expensive, right? What are those highest risk first?
Mhm. Well, and the patient is part of the partnership in that too, right? So the referring entity, which it here is the hospital referring her into this MIH program, what is the hospital's biggest concern as our stakeholder? It's going to be the 30-day readmission. It's going to be for the patient safety part of that, the fall risk and the problem list. So really, I think the COPD and the diabetes take priority for me as part of the biggest clinical piece of what we've got to get in place. If we had to pick the top three, I would have to say probably the new onset diabetes, the COPD, and then the lack of patient-centered medical home for me is going to be big.
Yeah, I would agree. And, I think that this is where sometimes in community paramedicine, you have to push up some of those social determinants if those are really impeding the therapeutic goals or, contributing directly to the risk of a patient ending up back in the hospital. So if you have a scenario where, yes, the COPD is top priority, yes, the diabetes is top priority, but she doesn't have a glucose machine or she can't afford the insulin, then those are social determinant of health related issues that are going to directly result in a treatment failure there. So, balancing that can really be a challenge for sure. So, our next component here is question two: what additional medical history can you gather from her discharge medication list? We went through that, I think, pretty well there. That, some cardiac issues occurring. She's on some things like DIG and also an anticoagulant. So we maybe have some AFib going on here. Obviously, a potential hypertensive patient. We did see multiple blood pressure medications. There may even be some heart failure or some CAD. Molly, anything else from the medications and the discharge list that would be a reasonable, differential of what kind of diseases we'd be looking at here?
Well, and it doesn't say so in the case, but we don't know. Does she have COVID? Did she get a PE from some type of COVID related event or some other type of community acquired pneumonia? There's a few things that are wanting. Since this is a discussion about taking a test also, while we're having high level discussion, I would just encourage as a test taking tip, never read more into the case than what a test question is giving you. That's one of the things that we talk a lot about when we're prepping students to take this IBSC exam. You have everything you need in the scenario to answer the question. So while it's tempting to have this differential diagnosis discussion, be careful to not read more into the question than what's there, right? So,
That's great advice. And it's something that, especially within this field of community paramedicine, I think every paramedic is going to struggle with because you're so used to assessing the patient at this moment, going through all of the different possible scenarios that the patient may be dealing with as they present with A, B, or C symptoms. And now we're taking off our EMS brain and we're putting on our community paramedicine brain, and we're trying to say, really, what are the situation components, or the clinical clues or whatever that really clue me into what the priorities are for this patient. And from a test taking standpoint, that's such a valuable tip.
Mhm.
So the items that would be prioritized, we've kind of already talked about that. So obviously for this patient, really representative of CP, we're going to be focusing in on the diabetes management and new onset diabetes, which anytime you see new onset, that's a great clue for some education that might be coming down the line for the patient.
Mm.
And obviously the COPD, which was the recent hospital discharge. So Molly, anything else we want to say about part one before we transition to part two?
Well, I think question 3 in part 1 about, the prioritization for developing the care plan, domain 5 of the IBSC CPC exam has to do with preventative care, education for the patient and caregiver. So there needs to be a knowledge base for community paramedics on what are the recommendations from American Diabetes Association, American Heart Association. You can't just say to a diabetic, you need to have a better diet. You've got to be able to nail out some really specific points on dietary intake, exactly how much sodium, exactly how many carbohydrates, and even some basic nutritional things like what's the difference between a carbohydrate and a protein, things like that. So I think that sets us up well for the next part.